So we are going to part 2, which is nothing but WHO classification and updates from previous WHO. You all know the current WHO is 4th 2017. So we will be expecting. And another thing, the whole literature area, they are telling rather than putting edition, let us start with the versions. Okay, they started with the CNS. You may be seeing so many updated articles. Why to wait for 5 years to get a edition? We will put versions so that every 6 months or every 1 year we can keep changing things. And you know, philosophically, change is the only thing that won't change. The picture taken in Lyon, you all know the WHO headquarters is in Lyon. So in January 2016, they had meeting, and this is my mentor, Dr. Lester Thompson. Okay, I love him. So I wanted to show his face to all of you. So all these people, they come up with the 4th edition. And there are totally 45 tumors they identified or they named in the 4th edition. Let us see what they are. Any tumor, first thing you have to see is whether they are primary or secondary. We are going to deal mainly with the primary. So the primary tumors should be divided into epithelial tumors, soft tissue tumors, and hematolymphoid tumors. These are all the 3 major divisions. In the epithelial tumors, benign, borderline, malignant, poorly differentiated, and tumor-like lesions. So this is the skeleton of the salivary gland WHO. The benign tumors, we have good number. I'm not going to read all these things, and please wait. Don't take a snapshot now. I will tell you when to take the shot. So these are all the tumors in the benign. Borderline, we have only xyloblastoma. Malignant, we have a big list of tumors. Poorly differentiated carcinoma, we have a good number. The neuroendocrine and non-neuroendocrine, like a small cell carcinoma, comes in the poorly differentiated carcinoma. Tumor-like lesions, they included now 4 conditions. Okay, we will be seeing these tumors again and again, these names. So, and in the soft tissue tumors that are specific, anything can happen, but specifically high incidence of hemangioma, lipoma, nodular fasciitis, and hematolymphoid tumors, you know, maltomas can happen in the salivary gland tumor. And this is the selfie time. Okay, take a snap of this slide. So if you count, if you don't have anything else to do, and if you count these tumors, you should get 45. So what are all the updates? The new entities, secretory carcinoma and sclerosing polycystic adenosis. The secretory carcinoma, previously it is called as mammary analog secretory carcinoma. But now they think another beautiful expression I got in one of the lectures is the salivary glands or breasts on the face. Okay, so that's why many tumors or many lesions that happen in the breast can happen in the salivary gland. And secretory carcinoma, they don't want to tell it is mammary analog. It is more common in salivary gland tumors. And so they got the new terminology, secretory carcinoma. Sclerosing polycystic adenosis, it is nothing but fibrocystic changes of the breast. Okay, rather than calling fibrocystic change of the salivary gland, they are calling it as sclerosing polycystic adenosis. The new names are polymorphous adenocarcinoma. Remember, previously we used to say polymorphous low-grade adenocarcinoma. But this polymorphous adenocarcinoma, some of the patients are doing very bad, and when they looked into it, they are all not that much low-grade. It can be high-grade also. So they put the new name polymorphous adenocarcinoma, and they removed the low-grade from that. And again, this polymorphous adenocarcinoma can be divided into low-grade and high-grade. Then intraductal carcinoma, this is the new entity. Okay, it is formerly known as low-grade cribriform cystadenocarcinoma. They thought they are all cystadenocarcinomas, but when they go for pathogenesis and histogenesis, they are all within the duct, and it's like a DCIS. What we call in breast DCIS, it's intraductal carcinoma. Okay, or ductal carcinoma in situ. Again, DCIS can be used here. And poorly differentiated carcinoma. Okay, so they put everything like small cell neuroendocrine, large cell neuroendocrine, undifferentiated carcinoma into poorly differentiated carcinoma, or highly undifferentiated carcinomas, or highly transformed carcinomas. Take a selfie of this. And then clarifications or changes, adenocarcinoma NOS. This is another major thing. The mucinous carcinomas and signet cell carcinomas and cystadenocarcinomas, now they are all included in adenocarcinoma NOS. Cystadenocarcinoma is removed as a separate entity, and mucinous adenocarcinoma is also removed as a separate entity. They are all put under NOS. And signet cell, please include signet cell carcinoma here. They are also called now as adenocarcinoma NOS. And then metastasizing pleomorphic adenoma, previously it was put in the malignant category because it has metastasized, but it is a pleomorphic adenoma. Previously, we used to tell metastasis is the criteria for malignancy. Now it is not. Leiomyoma can metastasize, pleomorphic adenoma can metastasize. So it's again brought under the benign category. Carcinoma X pleomorphic adenoma, there is a clarification in the terminology. And whenever previously we used to say carcinoma X pleomorphic adenoma as a diagnosis, now you have to say after that, what is the carcinoma component? Is it myoepithelial carcinoma? Is it adenoid cystic carcinoma? Is it acinic cell carcinoma? Is it salivary duct carcinoma? So you have to specifically state the histological type of the carcinoma, okay? And how much is the percentage of the component, malignant component. And minimally invasive, previously they thought 1.5 millimeter, but now they are trying to increase 4 to 6 millimeters. I will come back again when we see carcinoma X pleomorphic adenoma. And sialadenoma papilliferum is included in the ductal papilloma. Okay. And two other things, intraductal papilloma and inverted ductal papilloma, they are all included in ductal papilloma. So ductal papilloma now have three members: sialadenoma papilliferum, inverted ductal papilloma, and intraductal papilloma. And lastly, lymphadenoma. Previously, we used to divide them into sebaceous and non-sebaceous. We used to say sebaceous lymphadenoma and non-sebaceous lymphadenoma. Now they behave like the same. So they want to put it as lymphadenoma hyphen sebaceous type or lymphadenoma hyphen non-sebaceous type. And they included the non-neoplastic epithelial lesions, sclerosing polycystic adenosis, nodular oncocytic hyperplasia, lymphoepithelial sialadenitis, and the intercalated duct hyperplasia. These are all the 4 additional non-neoplastic epithelial lesions. I think this is a selfie time. So we are going to third portion where we will be spending most of our time. Okay, pattern analysis. We have to remember architecture and the cell type. Okay, so in the pattern analysis, and we are dealing only with epithelial tumors. Okay, epithelial tumors can be divided into 4 parts: pure epithelial, pure myoepithelial, mixed epithelial and myoepithelial, and epithelial with lymphoid cells. Okay, let us start with the simplest one. Epithelial with the lymphoid cells. The non-neoplastic is lymphoepithelial sialadenitis, and the neoplastic you have Warthin tumor, lymphadenoma, both sebaceous and non-sebaceous, sebaceous lymphadenocarcinoma, and lymphoepithelial carcinoma. Take a snapshot. So this is the picture where you can, it's very difficult to say it is salivary gland, but you can see the small nest of acini and the extensive lymphoplasmacytic infiltrate. And when you do cytokeratin 7, you can pick up all the acinar and ductal component. They are probably like 5% or 10% of the 10% component of this picture, but you can see a nice germinal center and more lymphoid cells. So whenever you see this, you think of lymphoepithelial sialadenitis. Okay, and whenever you see lymphoepithelial sialadenitis, look for fibrosis. Here in this picture, I don't see that much of fibrosis, but whenever you see lamellar fibrosis, lot of plasma cells, look into the major ducts, identify the veins there, and you can see inflammation of the veins, which is known as phlebitis. These are all the 3 main criteria for IgG4 disease. Super. This is a classic Warthin's tumor. See, some tumors, if you see once, you won't forget. Okay. Dense lymphoplasmacytic background, two types of cells, okay, large abundant luminal oncocytic cells and the peripherally compressed cells, abluminal cells, okay. This is nothing but Warden's tumor. And when these and they are all arising from striated ducts, okay, and these striated ducts, I told you the striations, and they will have a lot of mitochondria in them. And when you do anti-mitochondrial antibody, that will be positive in all the oncocytic cells, okay. This Warden's tumor. So this is lymphadenoma. This is a lymph node. You can see the normal salivary gland, nice circumscribed capsulated lymph node. You can see the lymphoid cells, and you can see some other pink cells. You can see some other glandular cells. And when you go to high power, you see the sebaceous cells. So this is lymphadenoma, sebaceous type, and this is all epithelioid cells, okay, but they are all morphologically very bland. So this is non-sebaceous lymphadenoma. And awareness of this is very, very important, because in frozen sections, okay, in frozen sections, if you are not aware of this, you may think these are all metastases, okay. But please look into the cytology. If they are bland, they are benign inclusions, sebaceous and non-sebaceous lymphadenoma. But you can get sebaceous carcinoma also there.
Sir, and there are two questions. If you would like to answer them
yes.
now.
Yes, madam. Yes, madam.
Cutoff for plasma cells, IgG4 related salivary gland disease.
40% IgG4 positive plasma cells. Okay, the cutoff is keep changing, and it depends upon organ to organ. Okay. But you see the number of plasma cells, and then do IgG4, and then see how many of them are IgG4 positive, not immunoglobulin. It is immunoglobulin G4. When they are more than 40%, then it is more diagnostic of IgG4 disease. But that lamellar fibrosis and phlebitis, they are more characteristic. Whenever I see histological pictures, I call my clinicians, I tell them, do a serum IgG4 level and look into the other organs. Okay, thyroid, what we used to call a Riddle's thyroiditis is IgG4 disease. Sclerosing mediastinitis is IgG4 disease. Sclerosing peritonitis, retroperitoneal fibrosis is IgG4 disease. And sclerosing pancreatitis is IgG4 disease. So whenever you see sclerosis, lymphoplasmacytic cells, it is IgG4 disease. Super, madam.
Yes, sir. Sir, one more is there. If lymphoid component is absent in the section, but bilayered oncocytic epithelium is present, can be diagnosed as Borden's tumor?
No, when you don't see lymphoid cells, it may be oncocytic hyperplasia. I will be talking about it later. So this is a benign sebaceous cells, whereas here it is malignant. Okay, so this is sebaceous carcinoma. And for the exam going postgraduate, so one good news, the exam is not going, exam is coming. So the exam coming PG is the sebaceous carcinoma is very common in the eyelid. Okay, any tumor in the eyelid, if you don't know, just write a description and sebaceous carcinoma. And if you look carefully, you can see the sebaceous cells, more like a microvesicular steatosis in the liver. That's how the sebaceous cells will look. Okay, there's two markers, adipofilin and EMA. EMA is very good. Sorry, this picture is hiding the adipofilin and the EMA. EMA is the most commonly used for sebaceous carcinoma or sebaceous cells. And you have to remember one thing, these immunohistochemical stains, they tell the cell of origin. They are not telling benign or malignant. For example, normal sebaceous cell lymphadenoma, sebaceous cell carcinoma, all are positive for EMA. That you have to keep it in mind. Another mixed tumor is a lymphoepithelial carcinoma. You can see a lot of atypia, a lot of mitosis, very atypical mitosis and lymphoid background. When you do cytokeratin, you can highlight the epithelial cells in a lymphoid background. And when you do EBER, this is more diagnostic of lymphoepithelial carcinoma. This comes under poorly differentiated carcinoma now in the new WHO system. Now we are moving to mixed tumors, pleomorphic adenoma, metastasizing pleomorphic adenoma, carcinoma X pleomorphic adenoma, epithelial myoepithelial carcinoma, and carcinosarcoma. They are the main components of mixed tumors. And carcinoma X pleomorphic adenoma, there are 4 components. Okay, in situ, intracapsular, minimally invasive. Most of the people follow less than 1.5 millimeters, but now the new WHO, probably you might have caught it in that slide, it is telling 4 to 6 millimeters. Okay, keep that in mind. and then widely invasive carcinoma. And how to differentiate these 4 types, we will see it in a minute. Take a selfie of this for tumors in the mixed category, mixed epithelial category. So pleomorphic adenoma, as I told you, 80% of the time it is pleomorphic adenoma in parotid. So cross section, very well circumscribed lesion, and see that chondroid appearance. Okay, the name, it has to be polymorphic adenoma. It is not pleomorphic. There is no pleomorphism. It is multiple forms, so it has to be more polymorphic. So, and a lot of stroma in the background. Okay, and this is a cellular pleomorphic adenoma where you don't see that much of stroma, and this is a pleomorphic adenoma arising from a minor salivary gland. You can see the squamous epithelium. In the parotid tumor, for pleomorphic adenoma, they won't remove the skin. Okay, and these are all again exam question and exam slide. Tyrosine crystals, and madam might have showed you in the cytology. When you see tyrosine crystals in the FNAC, you have to think of pleomorphic adenoma. Pleomorphic adenoma can show extensive squamous metaplasia, oncocytic changes, adipocytic metaplasia, and they may show nodularity. You remember that picture, but these nodules are very well circumscribed. They are not infiltrative nodules, and they may show a lot of bone and lot of myxoid degeneration. And this makes the FNAC very difficult. Okay, when you see the squamoid cells and the myxoid degeneration, mucinous background, we call it mucoepidermoid carcinoma. Okay, so when you see a lot of oncocytic changes, we call oncocytic neoplasm. But again, remember, pleomorphic adenoma is 80% in the major salivary gland. We have a lot of markers now, but the main marker we use is PLAG1. Why I love this? This is nothing but pleomorphic adenoma gene 1. And I kindly request, many of you will become scientists. I wish you all to get Nobel Prize. But when you are identifying something, you just name it on the condition. For example, I love dog, diagnostic on GIST. You don't have to memorize anything. Okay, so this is pleomorphic adenoma gene 1. We have IHC for that, and that is more specific. Okay, so and HMGA2 is also coming up, but this is not very specific, whereas PLAG1 is more specific. And other IHCs, WT1, P63, GFAP, I just put it for completion. If you want to do only one marker, go for PLAG1, especially in cytology, because histology, you don't need markers for pleomorphic adenoma most of the time. Whereas in cell block, as madam told you, try to do IHC only in the cell block, because in the smears, as madam told, the cells may go off, or you may not get a good quality control. Okay, you cannot run paraffin control for a cytology smear. This is a salivary gland, normal salivary gland. This is the pleomorphic adenoma. Okay, well circumscribed. In the pleomorphic adenoma, for example, let us take this gland. Within a gland, you can see malignant cells. Okay, so this is pleomorphic adenoma with the in situ malignancy within the basement membrane of pleomorphic adenoma and within the capsule. In this scenario B, you get the malignant cells within the basement membrane and they are spilling out, but they are not spilling out of the capsule of the pleomorphic adenoma. So this is known as intracapsular carcinoma. Remember the 4 terminologies we use in carcinoma X pleomorphic adenoma. This is in situ carcinoma X pleomorphic adenoma. This is intracapsular carcinoma X pleomorphic adenoma because it has gone beyond the basement membrane, but within the capsule of the pleomorphic adenoma. And when they extend outside, okay, I put here 1.5, but remember the new criteria 4 to 6 millimeters. They are not very sure this since it's arbitrary. But my thing is, when you keep it more than 1.5 millimeter, it will cover 4 to 6 millimeter also. So this is minimally invasive. When do you call it? They are spilled out of the basement membrane. They are spilled out of the capsule. They are coming into the parenchyma, but the distance in the parenchyma is less than 1.5 millimeter or 4 to 6 millimeter in the new criteria. And when they then you call it minimally invasive. Okay. And when it comes out and they extend more than 1.5 millimeter or 4 to 6 millimeter, then it is widely invasive. Okay, very simple if you understand this picture, but many times they come with widely invasive. These are all like incidental findings, in situ, intracapsular, or minimally invasive. Okay, most of the time what we see is widely invasive carcinoma, but this is a theoretical explanation for the 4 terminologies. Take a snapshot of this. Okay, so these are all the pictures. Carcinoma, explomorphic adenoma, you can see the malignant cells and they are within the capsule. Okay, so this is intracapsular. Here it is minimally invasive, they are coming out like in thyroid follicular carcinoma, mushrooming. Okay, so this is distance is less than 1.5 or 4 to 6 millimeters. So this is minimally invasive. And here it has come out. This is the border of the pleomorphic adenoma. Carcinoma has come out into the adipose tissue. So this is widely invasive. And whenever you find some atypical cells, you are not sure whether it is invasive carcinoma or not, you do the basal cell markers. Okay, and this is a double staining where they see the smooth muscle marker and P63. P63 will take up the nucleus. Okay, so here there are the atypical glands without P63 or malignant. So these are pleomorphic adenoma, whereas here it is carcinoma arising in pleomorphic adenoma. Okay, and P653 is also very helpful in identifying carcinoma ex pleomorphic adenoma, because in pleomorphic adenoma type, P53 should be negative, whereas in carcinoma component of pleomorphic adenoma, it will be positive for P53, and you can couple it with Ki67. Okay, don't do only P53. Even though this picture is very good looking, you may not get these nice pictures in real life. So always combine with P53 and Ki67. If both are positive, then the chances are more on the malignant side. So this is a salivary duct carcinoma arising in pleomorphic adenoma. Remember, you cannot diagnose carcinoma ex pleomorphic adenoma. After that, you have to qualify salivary duct carcinoma, salivary duct carcinoma 40%, acinar cell carcinoma 80%. Or adenocarcinoma arising in pleomorphic adenoma 30%. Like that, component of the carcinoma and what is the percentage you have to mention. This is another biphasic tumor, very nice picture. These are all, again, if you see once, you won't forget. You can see nicely 2 types of cells, luminal cells and abluminal cells. So these are epithelial cells, these are myoepithelial cells. It's invading into the parenchyma. So this is nothing but epithelial myoepithelial tumor. I told you the cytokeratin, low molecular weight cytokeratin will be positive for epithelium. Even CD117 will be positive in the epithelium, whereas P63 is positive in the abluminal cells. Okay, so when you do epithelial and myoepithelial marker, you can confirm the epithelial myoepithelial carcinoma, but believe me, it is a H&E diagnosis. Carcinosarcoma is the last one. This comes under polydifferentiated carcinoma or high-grade carcinomas. You can see the epithelial component and you can see the background malignant stromal component. In the high power, you can see better malignant epithelium and malignant stroma. So in the breast, they call it metaplastic carcinoma, but in other organs, they call it carcinosarcoma. So now we are going to myoepithelioma and myoepithelial carcinoma. Okay, and you see there are 5 types of myoepithelial pattern. Okay, they can take a stellate cell, star-shaped spindle cell, epithelioid cell, plasmacytoid cell, or clear cell. This is another university question. Okay, myoepithelial cells or myoepithelial lesions in salivary gland. Okay, please mention all these 5 and take a selfie of this. And here I am putting more plasmacytoid myoepithelioma, and here P63 is the marker. Here you can see more spindled out cells. Okay, so remember 5 types of cells in myoepithelioma. And when this myoepithelium is well circumscribed, it is myoepithelioma. When it is infiltrating, then it is myoepithelial carcinoma. Please remember that. No other criteria. Atypia mitosis won't be helpful in salivary gland to differentiate benign from malignant. Infiltration, speed of growth. Now we are coming to epithelial. And epithelial, you have to see the pattern and cells. There are 7 patterns you have to remember in the pure epithelial tumors of salivary gland, and 5 cell types you have to see. Take a selfie of this.